and I will be the moderator for this session. So in the beginning, for the first part of the session, it is our privilege and honor to invite to the stage Professor Tahir Rashid. He's head of department ENT, head and neck surgery, Amiruddin PGMI, and Lahore General Hospital. Please come to the stage, Professor Tahir Rashid.
I am Dr. Tahir Rashid. I work as professor and head of department of otorhinolaryngology, head and neck surgery, PGMI, Lahore General Hospital, Lahore. My area of interest is rhinology and head and neck surgery. So that's why this topic, it is very much related to the general practice, because I have done many years of general practice with my father, Dr. Abdul Rashid Musarrat. Dr. Aftab knows that. So I have a very long experience of this rhinology right from the general practice. So what is the percentage you people see in your clinic suffering from the upper and lower respiratory tract infections? Anybody can guess? 40, 50, 60, 70, 80%. So this is my experience. 80% of the patients, they are suffering from the upper and lower respiratory tract infection. And the culprit for that is the nose. If you improve the physiology of the nose, we can curtail these diseases later on. Anyway, let's proceed to the next. There is no fun to live with allergic rhinitis because it will hamper your quality of life. So way of living will be distorted with this allergic rhinitis. Today, my objective is to just have the concept of one airway and one disease. Right from the nose up to the lungs, it is one airway. And the mucosa of the upper and lower respiratory tract is the same. So both will behave in a same manner. If someone having a rhinorrhea, he will be having some secretion in the lungs also, in the bronchi. And there is a strong association of asthma and allergic rhinitis, and these can lead to the chronic rhinosinusitis, and these anatomical abnormalities in turn leads to the chronic rhinosinusitis, and environmental factors. These are the big problem nowadays. United airway or one airway disease. Most of the patients with asthma have a concomitant allergic rhinitis, and the presence of the rhinitis is a risk factor for the development of asthma. So those are interlinked with each other to a varying degree. Almost 30% of the allergic rhinitis sufferers have asthma, but 80% of the asthma patient will have some sort of rhinitis. So most of the asthma patient, they have rhinitis. So this can be a start of the disease. This is one airway, one disease, right from the nose up to the lungs. It's a one airway. The mucosa of the upper and lower respiratory tract, it is the same. That is pseudostratified columnar ciliated epithelium. In fact, in the sinuses, the mucosa is the same. In the eustachian tube, the mucosa is the same. So whenever there is secretion in the nose, congestion, there will be congestion in the eustachian tube, congestion in the lungs. So that can lead to the otitis media with the fusion, sinusitis, and the asthma. Both allergic rhinitis and asthma, they are type 1 hypersensitivity reaction. This is the allergy. And type of inflammation is same right from the nose up to the lungs. So what happens? These allergens are not dangerous to the body. A body recognizes them as a dangerous. So in the reaction of that, they produce antibodies. And in the next time when that antigen comes in, these allergens, they combine with the mast cell where the antibodies have already been placed. So this causes breakage of the mast cell, degranulation, and release of certain enzymes like histamine, certain chemicals, histamine, leukotrienes, prostaglandin, and eosinophilic chemotactic factor. These causes, they produce in response to inhaled allergens. So these causes the symptomatology of the allergic rhinitis and asthma. Like vasodilatation, hyperemia, mucosal edema, this will lead to the nasal obstruction and narrowing of the lungs. infiltration with eosinophils, and smooth muscle contraction. This will be caused by the leukotrienes. Allergic rhinitis can be allergic or rhinitis simply can be allergic and non-allergic. Similarly, asthma can be allergic and non-allergic. There are many causes for the non-allergic rhinitis or asthma. Asthma is also allergic and non-allergic and leads to difficulty in breathing, shortness of breath, cough and wheezing. And these are the signs and symptoms of the allergic rhinitis: nasal obstruction, nasal discharge, sneezing, itching nose and throat. But when you are seeing 80% of the patient or maybe 50% of the patient with rhinitis, you don't know whether it is suffering from the allergy or not. It can be a non-allergic causes. So that can be distinguished on the history and then later on some investigations. It's a very common condition. It affects up to 20 to 30% of the adult population globally, and in children this ratio goes up to 40%. Symptoms significantly affect the patient quality of life by interference with the sleep and poor performance at work. Diagnosis can be clinical, and later on we can do some test. I will show you that one. So history is the most important. If a patient has a history that after exposure to some allergen he has the symptoms of rhinitis or asthma, this is simple, this is allergy. As I am suffering also from allergy. I also have allergic rhinitis. So first is the history that will be positive for some allergen. Examination will sort out what are the allergic components and what are the non-allergic, like anatomical abnormalities, polyps, rhinosinusitis. Then these are the tests: skin prick test and the allergen-specific IgE antibodies. These are the specific tests to find out whether the patient is having allergy to specific antigen or not. And unfortunately, these are not present with us. Even in Lahore, nobody is doing this one. So you have to confine yourself to the history. And if these tests are not present, these cannot be done in Pakistan. So basic diagnosis of allergic and non-allergic rhinitis is positive skin allergy and positive serum specific antibody tests. And this is beyond, So 600 million people in the world, they suffer from the allergic rhinitis, and 400 million people from asthma globally. This is quite a big ratio, almost 30-35% for the allergic rhinitis and 15% for the asthma. Incidence of allergic rhinitis and asthma is higher in children and in certain families. Why it is higher in children? In small children, because of the adenoid hyperplasia, they keep on mouth breathing, so they have more asthma as compared to the adults. And even higher incidence has been found with air quality index, pollution related, like in Pakistan. This classification was prepared by the allergic rhinitis and its impact on asthma. So previously it was seasonal and perennial allergic rhinitis. That has been now divided into intermittent and persistent. If the symptoms of rhinorrhea or asthma, they are present for less than 4 days per week, and this is for less than 4 weeks, so 1 month, we will call it intermittent. Persistent means more than 4 days and more than 4 weeks. So this persistent can be a mild, or even intermittent can be moderate. But this is the group, persistent, whether it is mild or moderate to severe, this is related with the asthma. So it is a persistent symptoms, whether it is mild or moderate, this will lead to asthma. And the treatment of that is, this is mild, intermittent, moderate, mild, persistent, and moderate to severe. Keep this immunotherapy. The treatment of allergy is avoidance, and number 2 is the immunotherapy. The rest of the treatments are symptomatic. So when a patient comes to you, with symptoms of rhinitis, what we do? We give them intranasal decongestants or oral decongestant or oral local non-sedative H1 receptor antihistamines in this group. That is very mild. But if this is a moderate to severe, we can add intranasal steroids. This will reduce the edema of the mucosa. Then mild persistent, we can add intranasal decongestants and all these. This is the area where immunotherapy work. And in Pakistan, there is only one center in Islamabad which is doing this. But the allergens for every city are different. So this has been everywhere in every city to find out the allergens. So this is not very good nowadays in Pakistan, and it's a very long with injections. There is a new form, that is a sublingual immunotherapy has been introduced, but that is still in America. Now, these are the rhinitis patient and these are the asthma. But there is a overlap in both of them. This is a group which need immunotherapy. If a patient is having only asthma, we don't need immunotherapy. So immunotherapy is required for allergic rhinitis and a patient who have allergic rhinitis along with asthma, this group, in which you can give anti-leukotriene also. But in allergic rhinitis, we don't give anti-leukotrienes. In asthma, beta agonists are important, and this is a group which need anti-leukotrienes and immunotherapy. As I told you, one airway, one disease. And similarly, the allergens are similar for both of them. Right from the wheat pollens, house dust mites, pet's dander, cockroaches, trees pollens, all these are responsible for the allergic rhinitis and asthma. So this is a relation with the pollution. So air pollution can have a serious impact on allergic rhinitis. It aggravates the symptoms, impact the psychological and physical well-being, and the ability to perform at work. Impact of allergic rhinitis in Pakistan. In fact, it has been found in this study the alarming situation. That is, Pakistan is having a 42.3% cases of allergic rhinitis. So this is globally very high, and this is attributable to what thing? Air quality index. क्या है वो? Very unhealthy. This is a normal 200 to 300 in Lahore. So that's why most of the people having this problem of asthma and allergy. Management, allergen avoidance. कैसे करनी है? House dust mite, cleaning of your house, bedding, house dust mites. The major source of house dust mite is your bed. This enemy is there. There can be another enemy, but this enemy is for allergic rhinitis. The other enemy is for some other reasons. And what happens? You keep on using that linen. So every week you have to clean that linen with hot water. Then your filters for your AC, you have to clean that one, vacuum your carpets. All these will remove the house dust mites from the house. This is a major source of allergic rhinitis and asthma. Then allergen avoidance is with the help of masks. You can avoid the pollution and other things. Medicines, there is a nasal congestion, nasal blockage, cough, all these things you can use antihistamines. We are using that one, decongestants. These are only the symptomatic treatment. Anti-inflammatory therapy, this is in the form of intranasal corticosteroids. In asthma, we give steroid inhalations also. And allergy immunotherapy. This is a definitive treatment against that allergen. But unfortunately in Pakistan, the role of this is very small. In recent advances, there is a combination intranasal corticosteroid and antihistamine. So both will be present in one puff. So we can give antihistamine and steroid intranasally or by intranasally. That will reduce the systemic side effect of the disease because the patient has to use that for a longer time. And there is the introduction of sublingual immunotherapy. This is in the form of pills. If you can find out the allergen, they will prepare a immunotherapy for you, and instead of vaccine giving by injections for 3 years, you have to use a tablet. But this is not available in Pakistan at the moment. And future is the introduction of the intralymphatic immunotherapy. They are still working on that. This is the future management. Allergic rhinitis and pollution I have already discussed, so we have done this one. This is a study which shows a clear-cut relationship with the symptomatology of the allergy and asthma with the pollution. So FAX is for fexofenadine, POL for pollution, and SAR for seasonal allergic rhinitis. So this study was conducted, this is a big study, was conducted in Canada in an environmental exposure unit. So they collected a group of people who were sensitive to ragweed. Whenever they are exposed to ragweed is a pollen there. So when they are exposed to that, when they produce symptoms of nasal obstruction, rhinorrhea and sneezing. So this is a total nasal symptom score. We score them, and they were in this unit. They were exposed to the ragweed pollen, and they find out they calculated the total nasal symptom score in the form of rhinorrhea, sneezing, and coughing. So after that, they were given a period of 12 hours, and every hour this score was calculated. 2 weeks later, they were brought back again, and this time they were given ragweed pollen along with diesel exhaust particle pollution. And that time, the total nasal symptom score was very high. So that showed a definitive relation with the air pollution. And third time, they were brought back again, and they were given ragweed pollen, then diesel exhaust particle, along with they gave a dose of fexofenadine 180 milligram. And the results were I will show you in the conclusion what were the results. Air pollutants can significantly increase the seasonal allergic rhinitis symptoms that we discussed in the first group. And fexofenadine is an effective and well-tolerated treatment that has been shown significantly alleviate these pollution-aggravated symptoms. So with this, I will finish my talk with the one airway, one disease, that is allergic rhinitis and asthma. The take-home message is again that the clean avoidance of the allergen and go for the immunotherapy. We all have to work for that in future. Thank you very much.